Lyme disease has an acute illness. It's like a flu. You can get a rash, you get headaches, you get sick, you get a fever. So we know this is not the controversial portion of Lyme. Yes, people get Lyme every summer. There's a tick-borne season. It has about a 1 to 3 week incubation period. So you get bit and then usually you start to get symptoms a 1 to 3 weeks later. This is not what people argue about. The argument is about what happens about 20% of the time, 10 to 20% of the time. Ten to 20% of the time, Lyme disease can cause chronic, mysterious, long-term illness. This typically takes about 6 months or a year to ramp up. And so sometimes by the time patients are going, oh my gosh, I have chronic fatigue or fibromyalgia or very mysterious neurological effects of, POTS, anxiety, depression they've never had before, just absolute havoc on their health system, they can't even remember that they got bit by a tick 9 months ago or 6 months ago. So the argument portion isn't on the acute phase. The argument portion of Lyme is on what do you do with this sub-portion of Lyme patients that seem to have their health completely unravel from this condition.
So is that what chronic Lyme is?
Yes, the term chronic Lyme, once again, people argue over how good that term is. But what we're really saying is 10 to 20% of Lyme disease does not self-resolve. Your body cannot kick it out. And once your body cannot kick it out, it creates a chronic inflammatory state in the body, which leads to a diffuse set of mysterious symptoms. There's controversy on treatment. There's controversy on testing. There's controversy on how common it is, how uncommon it is. There's controversy on how long it lasts and what it does. So this is a huge kind of argument happening in the medical community. Now I'd like to point out, and I do point this out with my patients, is this actually is not as uncommon as we thought. If you look at the other famous spirochete, it's called syphilis. So if you read medical history, syphilis has 3 stages, and it doesn't always go to all 3 stages. In fact, most of the time it went to stage 1 and it didn't go to stage 2 and stage 3. It was only in this small subpopulation that syphilis caused complete and utter havoc. If you look at a disease like polio, now most people know polio because our president, Franklin Delano Roosevelt, had polio, and it causes this neurological paralysis problem. Well, it only does that a small percentage of the time. Some people say 1% of the time, 1 to 5% of the time, what most stats look at. And so Lyme disease is not the only disease that a good majority of the time presents in this, oh, I got a flu, oh, I got sick, and then I got better, and then that's the end of it. But in a small percent of the population, and small being 1 to 20%, depending exactly where you're looking, it causes more problems and people don't just get over it. This topic of co-infections is when I go to ILADS conferences and Lyme disease conferences with doctors, is one of the biggest things you see variance in between doctors. A saying that doctors say, tick is nature's dirty needle. Meaning these ticks live and eat mice blood and deer, and these things don't just have Babesia or Borrelia or Borrelia is Lyme, Babesia is a common co-infection. They often have multiple things. So when you get bit by the tick, it's not like you just got one present. You got a whole hoopla of stuff that just went into your system. And this is also what makes each case a little different. So if you get Borrelia with Babesia, or Borrelia with a virus, or Borrelia with Bartonella, these are things that start to really make each Lyme presentation very, very different, because you get a different cocktail of microbial bugs that are now, we call them the monkey piling on your back and dragging you down. But it can really make each patient a little different, because it's not about just Borrelia or Lyme. It's actually kind of this weird conglomeration of you just got bit by a very, very dirty bug and probably got a couple things in your system at the exact same time. There's a certain amount of Lyme doctors and Lyme practitioners who just assume you have all the co-infections. They go, I'm not even going to spend any money testing, I'm just going to assume you have them all. And we're going to approach it that way. That leads us into how accurate is all the testing. But I will tell you, that's a somewhat safe assumption that a lot of doctors make, is we just assume this is an absolute mess and you probably have 3 or 4 or 5 things at the same time with the Lyme every time.
That's such an interesting point of view. I've been tested for Lyme and I was told the test came back negative.
Yes.
Assumed I don't have Lyme.
Sure.
But I feel like I do.
Right.
I'm not really sure.
Oh, this happens a lot. So this is a kind of a different argument in how the testing criteria is interpreted. So standard CDC criteria is they run what's called an ELISA test, and then if that's positive, they do a blot test, either a Western blot or an immunoblot. And then on the blot test, it's matching bands. I tell people the coolest part about this is they glow kind of neon, which for a nerdy scientist in college was like, ooh, we're in a lab and something glows. So this is kind of a fun test to run, because I literally remember running these things in college. But you're trying to match, 5 out of 10 have to match for you to get diagnosed with Lyme. Now the CDC says directly on their website, this is really not to be used for a clinical diagnosis. It's not really designed for doctors to use it as the criteria. And in fact, IDSA, which is one of the societies for Lyme, has completely different criteria, which is much more based on the clinical presentation of a patient. So between the CDC and IDSA, we have actually pretty different criteria, published criteria, on exactly how to diagnose Lyme. So welcome to some of the controversy in between some of the biggest organizations here. But most people will follow CDC criteria. And there are some big problems with this. This is really set up for epidemiological surveying, not for the clinical diagnosis. It's set way on the side for if it's positive, it's absolutely positive, but we're going to have a ton of false negatives. We are not going to have almost any false positives on the CDC criteria. We're going to have a ton of false negatives. So we have a lot of patients who go, yeah, I got tested and they said it was negative. Now, what we do is a couple things, and I really like what Dr. Richard Horowitz says. He's got some great Lyme published books and published materials, is if I just run the blot. I don't like to do the first test and the second test. I like to just run the blot. And there are some bands that I say are very promiscuous. So for example, band 41 will test positive a lot, okay? But other bands are extremely specific to Lyme. And he looks at it and says, if any of the specific Lyme bands, like band 23, 83, 93, and a few others, he goes, are very specific. If you have the clinical presentation and you're matching some of those bands, he's going to make the clinical diagnosis of Lyme. So what we do in the office is a mixture of making sure you get some more thorough testing than just the initial screener test. A lot of people get that initial screener test. You want to try to get the blot, and then you have to realize that there is some wiggle room in the interpretation of that blot, particularly when you have a lot of the symptoms as well. The testing with Lyme disease and the co-infections is a huge topic for debate. Now, Dr. Paul and I love tests, but we also are not naive enough to think that tests are perfect. And I think that's what so many patients tell me. They go, I just want it to be so clear. And I go, we're going to do some of the best tests available to see if we can gain clarity. I have a regiment of tests, But this has been a journey. I tell people I'm on kind of phase 3 of my Lyme journey. We started this 6 or 7 years ago. And the way we test and the way we treat and help people with it is very different than it was 6 or 7 years ago. When I first started, there was a lab company, which is wonderful, and you can read all about different lab companies, but Lyme testing was incredibly expensive to get anything that was even reasonably had some reliability. I mean, we're talking, $1,500 to $2,000 for a Lyme plus a co-infection type test. And that's a lot of money. That's a lot of money to really just answer the question of, is this Lyme or not? I mean, it doesn't answer, is it mold? Doesn't answer, do you have inflammation? Doesn't it? There's a whole bunch of other tests that you can run. That's a pretty expensive mark for people. And so one of our searches for the last 6, 7 years is, okay, how can you get a reasonably accurate lab for a price that makes sense for many patients? Because I got to tell you, when the lab was $2,000, I didn't run it very much. It was a little outside of a lot of patients, price range. So what we have been able to get down, long story short with testing, is I usually run 2 tests for Lyme. Now those 2 tests cost about $250. But we think that those have hit the value, cost-value ratio for so many people if I'm suspicious. So we like that procedure. I also like to test for the 2 most common co-infections in Minnesota. So I will routinely run the 2 most common co-infections with Lyme, and it's all under $500. Now you can run more, and we talk about that with each patient who walks in our office, but we often think that running the most common things in Minnesota, double checking the Lyme through 2 different methods, gives us a very good, cost-effective way to evaluate Lyme in people who are coming in to see us, always correlating it with the clinical symptoms and clinical picture for a patient.
Sure. Do you still need to run these additional tests if someone has already been diagnosed with Lyme or treated for Lyme in the past?
Well, that's a great question. So if you've already been diagnosed with Lyme, we do stuff just a little different, because I already know you had it at one point. And then the question we're asking is it gone? Are you over it? Or is this still causing, problems? Because you had Lyme 5 years ago, does that mean all your problems today are coming from Lyme? The answer might be yes. And the answer might be no. So if we know we have Lyme in the past, I tell you we are suspicious, because it can, kind of pop back up for some people, or they don't get fully over it. But that's something we have a lot of questions we ask about that if it's in your history. And I'll do a little bit different testing procedure to see if we're still really struggling with that. But it's an important question to ask, because we find both assumptions on a case, which is, you had Lyme, you're over it, so therefore none of your problems can come from Lyme ever again. And then we also get practitioners that will blame everything on Lyme once you've had it. So nothing else ever can be thought of because you had Lyme once, so then nothing else is on the radar. And so we find that in both circumstances. So it's important to try to not make assumptions and try to look at an open mind and say, are your problems still coming from the Lyme? Or is there something else that has happened that we need to make sure we don't just assume it's all the Lyme and then we miss, this other thing?
Sure, definitely. Is the treatment the same regardless of the co-infections?
Is the treatment the same regardless of the co-infections? No. Certain co-infections, so for example, we alter our protocol if you have a real bad viral infection. So there's different things you want to do for viruses, both Epstein-Barr viruses, cytomegaloviruses, other viral problems. If you have Babesia is a red blood cell parasite. I always tell people, if you're interested in it, read about malaria. It's like malaria, it just doesn't kill you. And to be blunt, if in America it doesn't kill you, we don't spend a lot of research on it. It just makes you miserable, it doesn't kill you, we're not going to spend money and time on it. Babesia, like I said, is a red blood cell parasite. Anaplasma is a white blood cell parasite. And so these different things, because the physiology is a little different, because they're in different cells, you really have to approach them with some subtle differences. There's some commonalities for sure, but there are differences depending on kind of what you're presenting with for some of these co-infections.
Thank you. That's very helpful.